Bismillahirrahmanirrahim. Alhamdulillah wa salatu wa salam ala Rasulullah wa ala alihi wa sahbihi wa sallam ajma'in. Here today I will deal with the case discussion about this X-ray and CT scan. As we see here in this PA view of the chest X-ray, we see the heart is on the right side, dextrocardia, and the aortic knuckle is on the right side, and the stomach, it is also on the right side. And also we see some increased bronchovascular marking in the both lower lobes. On the magnified view of the lower chest, we see that the tubular structures are representing slightly dilated bronchi, segmental bronchi with wall thickening and some impaction on it, indicating some sort of bronchiectasis. On the CT scan of this patient, we see that bronchiectatic changes involving both here the lower lobes and here the middle lobe. It is on the left side because it is situs inversus, and here also the lingula, and we see the bronchiectatic changes with wall thickening, giving the appearance of the signet ring appearance. And also we see scattered tree and bud opacities due to mucus impaction in this patient. What is the differential diagnosis? What are the differential diagnoses? If we want to discuss the differential diagnosis, we want to exclude cystic fibrosis, but in the cystic fibrosis we see the upper lobe predominant, and also patient, it is presented in the earlier life, and there is not associated with situs inversus. And also another differential diagnosis, it is William Campbell syndrome. And this William Campbell syndrome, it is a congenital disorder due to defect in the cartilage, and it is occur in the 4th to 6th decade, 4th to 6th bronchial generation, and presenting either diffusely or in one focal area of the lung, and the lung distal to the bronchiectasis may be emphysematous, and there is also no extrathoracic manifestation as situs inversus. So we left with one diagnosis. It is primary ciliary dyskinesia, and the primary ciliary dyskinesia, it is sort of ciliary dyskinesia. Spectrum of ciliary abnormalities include the ciliary akinesia, dyskinesia, or aplasia, and it is lower lobe predominant, and 50% have situs inversus. And this primary ciliary dyskinesia, it is an autosomal recessive disease with definite diagnosis due to genetic counseling. Most men of these patients are immotile spermatozoa, and patients can be screened by exhaled nasal nitric acid, and this can be minimal or absent. Situs inversus occur, as we said, in about half of patients of the primary ciliary dyskinesia. What are the radiological manifestations of primary ciliary dyskinesia? We have moderate hyperinflation of the and the bronchial wall thickening and bronchiectasis. As we said, the bronchiectasis, it is predominantly in the lower lobes, and we have also small centrilobular nodules seen on the high resolution CT scan, and the bronchiectasis can be cylindrical or varicose or cystic, and sometimes giving the appearance of signet ring appearance, as we see in our example. And also the patient may have nasal polypi and aplasia of the frontal sinus. And the primary ciliary dyskinesia, as we said, associated with cardiac abnormalities like a transposition of the great vessels, biliary stenosis, and epispadias or other association. What is the relationship between Kartagener syndrome and the primary biliary dyskinesia? The Kartagener syndrome is a subtype of primary ciliary dyskinesia, and which is situs inversus, has situs inversus, sinusitis, and bronchiectasis, and there is lack of bronchial tapering or visualization of the bronchi within 1 centimeter of the pleura seen on the high resolution CT scan. Primary ciliary dyskinesia can also presented with recurrent pneumonia and scarring and mycetoma formation and hemorrhage. Thank you for listening, and hoping to see you soon in another talk.